because we're going to be speaking to Dr. Madeline Paul. And Dr. Madeline Paul, there she is right there. And she's been a speaker at many times about different topics. And she's done some podcasts for us about pregnancy and kidney disease. She's been a nephrologist for many years and is seen as someone who is extremely knowledgeable in the field of kidney disease. She works at University California, Irvine, and a nephrologist, and we're really excited that she's going to talk about the kidney demystified. And the goal for this presentation really is for us to understand what it does when our kidneys work and when they don't work, and be educated to inform others. Thank you, Dr. Paul, for presenting.
Well, thank you, Lori, and for everyone for inviting me. And that was an excellent lecture we just heard. But I want to start saying, I just today had a little contact lens drama in one of my eyes and gotten a little inflammation. My vision is not what it should be, so I may not be able to read what it says on the chats for the questions, but I'm going to give it a whirl and see how it goes. I think the drops are working. But anyway, I was asked to give a lecture on what the kidneys do. And I'm going to try to cover this in the next few slides. Of course, we think the kidney is the most wonderful organ and would require more than just a few slides to talk about it, but I'm going to give it my all right here. So as everyone knows, the kidneys are paired organs, and they're in the back of the abdomen. I put this slide that everyone knows to show a couple of things. One is renal size or kidney size. So you see that the kidneys are about, in an adult, about 11 centimeters in length. And sometimes if people have some kidney problems, for example, in polycystic kidney disease, the kidneys can be huge. And in people who have chronic kidney disease and are identified once they already have significant kidney failure, their kidneys can be small and shrunken. And sometimes the doctors tell you that, and you can see the sizes that we're looking at. I put also here kidney volume, which would be to figure out the volume of the kidney, because recently, when people are looking at particularly patients with polycystic kidney disease, as to whether they would benefit from available therapies such as tolvaptan, people measure the kidney volume and give you an idea. If your kidney volume is very high, you might benefit from this treatment. If it isn't, it's not. So just to talk about the concept that kidney volume is now being discussed. Also, you know, each kidney is supplied by one artery and empties with one vein. And I put that part in there because sometimes when we're evaluating potential kidney donors to give a kidney, if they happen to have the unusual but could be totally normal variant of having two kidney arteries or renal arteries, sometimes the surgeons would like to choose someone else because the surgery is easy. Okay, it's not impossible, but it gives you an idea. Everyone knows then that kidney drains into little tubes called ureters. The urine goes in the bladder, and then you hold. That's kind of the anatomy part. But what I'm supposed to focus on is the function. What do they do? So overall, the function of the kidney is to maintain the right balance of fluids, electrolytes, maintain blood pressure, make sure you're not losing minerals, get rid of your acid, or retain your bases in your body, okay? So how do they do that? The kidney basically filters the blood volume. It filters the whole shenanigans. About 40 gallons of fluid a day. Fortunately, the rest of the part of the kidneys reabsorb the stuff you need to keep. Okay, so in the end, your urine volume is, I wrote it here in quarts, but we all know it's about around 1.5 to 2 liters of urine a day. And that's what everyone thinks about the kidneys. The kidneys clean the blood through this process that we're going to talk about. But the kidneys also produce certain hormones and that help maintain blood pressure, help maintain your red cells, and help maintain active vitamin D. Those are the big ones, which is why most kidney patients know altered blood pressure, mostly high blood pressure, is a consequence of kidney disease. Anemia is a consequence of kidney disease, and we need to supplement vitamin D, otherwise you'll get bone disease as a consequence of this. Okay, so how do you make the urine? The number one work of what people think of as the kidney, and it's done through the part of the kidney called the nephron. And each kidney has about 1 million, 1.2 million nephrons. Okay, and what's the nephron? The nephron has the blood vessel part that's called glomerulus, and you've heard about glomerular diseases. And this is the guy that filters those 40 gallons of fluid from the blood. It goes into all these little tubules where then it's reabsorbed or things are secreted until you get what's the correct balance for you or for that moment in time, which is the urine. Okay? So the functioning part, this glomerulus, I show you in this kind of microscopic view in this cartoon, is basically this tuft of a blood vessel that has a barrier, a filtration barrier, okay? And that's the one that, because a little pressure is exerted through there, you get rid of water. It gets rid of toxins that are small enough that pass through that barrier. And it gets rid of other things like sodium, potassium. These are electrolytes. It gets rid of substances that come from other parts of the body, creatinine that comes from muscle, urea that comes from protein and breakup of protein products like uric acid, phosphorus, glucose, all those things come out of there. And if you see in this drawing, what has happened is they've taken a cross section of this area and put it as if you would see it under an electron microscope or tiny, minute vision, and you'll see that this is the inside of the blood vessel, these little tough guys. And you see how they draw the cell with little breaks called fenestria. That's the cell that lines the blood vessel called endothelial cell. And through there, into the urinary space, goes these filtration products. And you'll see there's this blue guy. This is the basement membrane. And then these are cells that sit on top of there. These belong to the kidney part. This is a blood vessel. These are called the podocytes. And they have these little foot processes. You may have heard this before. Another little barrier, okay? This barrier is what sometimes goes awry when you have many kidney diseases called glomerular diseases. Now, those sounds like a word maybe you've heard, maybe you have not, but the most common cause of kidney disease in adults is a glomerular disease caused by diabetes. And diabetes alters this beautiful anatomical structure that then allows stuff to leak out, and you don't initially, which is why they check for urine protein or albumin that comes from your blood. It should have stayed in the blood, but it leaked out, okay? And if it's inflamed, sometimes little red cells leak out there. You get, that's called proteinuria when you lose protein, and hematuria when you lose blood. And these are the symptoms of kidney diseases. We traditionally describe kidney function based on the kidney's ability then to filter the stuff we talked about. Okay? As that area starts to get damaged and scar, the amount of filter you can put out reduced. You can't clear the things in your blood. And some of these compounds that you should have been clearing build up. If you build up too much fluid, right, you get swelling, get edema. If you build up too much creatinine or other compounds like cystatin C, then your kidney function is said to be reduced because they're used as surrogate markers of that filtration process. And we call that, right, glomerular filtration rate. Most of you know it's called the GFR now. Nobody actually says the word. And often you'll see in your lab tests, you'll get little e GFR. So what is that? It's a measure of kidney function. And it's usually obtained most recently by using mathematical equations, plugging in the level of creatinine, more recently, cystatin C, another compound, and generating a GFR number, okay? We used to do 24-hour urine creatinine clearances, but no one wants to collect it. Half the time the thing is missing some volume or the lab spilled half of it. So it is more accurate often to get these other measures. And you can also sometimes measure it with imaging techniques or radioactive isotopes. But utilizing these compounds to measure this rate of filtration, you all know you can determine how well or poorly, I guess, the kidney is working. And I'm sure many of you know about this table, know about how we staged the GFR in levels of 1, 2, 3, which is divided in 2 parts. Sometimes people don't realize nephrologists will also give how much protein you're losing by using these albuminuria stages, okay? And you can see in this table the stages of kidney disease, and you'll see most dialysis patients have GFRs less than 10, okay? And we call that end-stage kidney disease. Now, just as a sideline to comment on what people may be interested in, kidney function deteriorates with age. We should say normally, but ideally it should remain the same. But as we all age, it does deteriorate. And we think it's largely clinically insignificant. And I put that on there because many patients who are 70 or above and sometimes in their 60s will get a serum blood test creatinine or cystatin C that suggests they may have GFR stage 3, usually 3A. Traditionally, that has not been associated with significant progression if the only cause is due to aging. So I say that because there's been a slew of patients identified once they started using these GFR stages and providing the eGFR on the lab test that causes a lot of anxiety among people. But having said that, we all know chronic kidney disease is a silent disease that's relatively asymptomatic until this GFR is very low. And so it's important to get the lab test and understand these issues because while we cannot cure kidney disease, progression can be slowed with a variety of methodologies, and it's important to be identified and treated. So we should catch it early, and screening includes blood testing for the things we talked about, creatinine, cystatin C, urine tests looking for the presence of blood or extensive albumin in the urine, and looking for high blood pressure, and then risks for those people that have risk for kidney disease, those that are diabetic, have pre-existing hypertension, family history, certain diseases, and certain ethnic background. I put this in here, even though I'm not supposed to be talking about chronic kidney disease, but rather the function of the kidney, because I think all patients should know what their numbers are. Figure out what your spreadsheet is, know your serum creatinine, know what your GFR is, and know how much of this urine albumin you have in milligrams per day or milligrams per gram of creatinine. And here are the values that are considered normal or abnormal. Okay, so now all this urine, now back to the original topic of the kidney function. You have all this urine that's basically filtered. And that's the ultrafiltrate, we call it. It comes from the blood. How do you end up from 40 gallons to a few quarts of urine a day? Because these tubules, named the proximal tubule, the loop of Henle, the distal tubule, and the collecting duct, all have jobs in reabsorbing the compounds. For example, they reabsorb water. They reabsorb electrolytes, acid. They regenerate the bicarbonate. They reabsorb glucose and a host of other things, okay? The tubules also try to control what's in your blood. They actually can actively secrete compounds more than what were filtered in order to get rid of things. For example, uric acid, hydrogen to get rid of acid. And they do this in order to maintain the normal homeostasis. And I put here so you can see, for example, certain parts of the kidney have more important functions in maintaining some electrolytes than others. Some people may have, as children particularly, but sometimes adults, given the diagnosis, for example, of distal renal tubular acidosis, and you would see that that's where a lot of bicarbonate and is reabsorbed is in the distal nephron. Right here also, you see glucose is largely reabsorbed here in the proximal tubule. And now many of you, particularly diabetics, will realize these new medicines like Jardians or these, I've taken advantage of understanding this and block where the kidney can absorb glucose. And so you urinate the glucose and get rid of it. So you can actually alter these things in diseases or for the purposes of pharmacologic intervention, okay? So what are some of the known abnormalities of the tubular functions of the kidney? I talk just a little bit about this because most of the time people are focused on the glomerular diseases, which I gave you a brief overview about, but they don't usually discuss the tubular functions. But these abnormalities are present in many kidney diseases, even if they're not primarily the problem. So for example, in many kidney diseases, there's an abnormality in the way the kidney can get rid of sodium. There are diseases where you absorb too much of it. And what do you end up getting? High blood pressure, hypertension. You swell, you get edema. Or, less common, but there are some who have what's called salt-wasting nephropathy. These are particularly diseases of just the tubules. And these patients can present with dehydration, low blood pressure, okay? And so those are the issues associated with sodium transport. Abnormal water transport in the kidney is actually handled separately than sodium. And that the most common abnormality there is if people cannot excrete enough water, you'll get taken to the nephrologist with the diagnosis of hyponatremia. And it's because the kidney is not responding normally, or because there is too much of the hormone called anti-diuretic hormone. There are certain tumors, certain drugs that can cause too much excretion of this hormone. It makes the kidney retain water and not excrete it as you should. In that case, it's called inappropriate, and it's the syndrome of inappropriate antidiuretic hormone. And people present with low blood sodium because you're waterlogged. Kidney won't get rid of the water. So the easiest treatment is to reduce water intake, which can sometimes be very uncomfortable. People are thirsty. And there are drugs, again, such as tolvaptan, that can make you excrete water and correct some of these problems. The other side of the coin is when you don't have anti-diuretic hormone, like something happened in the brain that makes this hormone, or because the kidney doesn't respond to it. It's had disease, and then you are excreting too much water, and you get diabetes insipidus. Those are these usually young kids. They make a lot of urine, and they have to constantly drink water. You can also get abnormal bicarbonate retention or abnormal acid excretion. These are the tubular acidoses, and there are distal, I said before, proximal renal tubular acidoses, and these can result in abnormal balance of the acid base in your blood, often also involve potassium, and they're a result of tubular abnormalities and can be managed depending on which one you have. You can also have abnormalities of the way the kidney handles calcium and phosphorus. Okay. Every patient with kidney failure knows about phosphorus specifically because the kidney is supposed to be excreting it. But as its function is reduced, it's unable to get rid of the phosphorus. So it starts to build up in your blood. We make people eat less phosphorus. That's only marginally effective. Then we try to bind the phosphorus from the food in the gut with a bunch of phosphate binder pills. Ideally, we should be looking at ways to increase excretion, but those processes have yet to be developed, except for, of course, in a kidney transplant when you restore the function of the kidney. Abnormalities in calcium, for example, if you excrete too much calcium in your kidney, traditionally you'll get kidney stones. Sometimes you actually start depositing calcium within the kidney itself, causing what's called nephrocalcinosis. Magnesium, most of which is absorbed in this loop of Henle, can also have abnormalities. These are mostly genetic abnormalities that then result in low magnesium. And one of these is Gittleman syndrome. There are a variety of disorders of these tubular functions that then results in many diseases. So you see, while we focus on the glomerular filtration, the amount of function the kidney has for cleaning the blood, the ability of all the tubules to do their work are also is also very important, so that that correct homeostasis is maintained. Now, kidney, that's the clearing and then the reabsorbing part. The kidney also is like an endocrine organ in that it produces hormones. The kidney is the site of something called renin. The renin production is one of the stimuluses of the production of the renal renin angiotensin aldosterone system. And this system is largely required to maintain blood volume. Okay? If you completely would block this out, the kidney would not be reabsorbing sodium properly. You would start to lose tons of it, which would then drag water, and you would be very dehydrated. Diseases that don't have the adequate, for example, aldosterone response to this, called Addison's disease, can present with low blood pressure and abnormalities in the sodium in your blood and dehydration. Traditionally, the concern, particularly in high blood pressure, is that you have too much of this effect and you have too much angiotensin 2, which in fact is also, in addition to stimulating aldosterone, causes blood vessels to constrict. So this causes high blood pressure, hypertension. And the pharmacologic response to this abnormality has been the generation of now a multitude of drugs you're familiar with. For example, the angiotensin converting enzyme inhibitors that block this, angiotensin receptor blockers that block this effect. And these medicines are lisinopril, enalapril, valsartan, losartan. So these agents have been shown to be very effective in the treatment of high blood pressure. And interestingly, many of you know they're given also kidney, because these hormones, in addition to having effect on blood pressure, have direct effects on the kidney that can cause kidney scarring, can promote more loss of the albumin through the glomerulus. And so when you block them, you protect the kidney and reduce progression. Okay? What is the other hormone that is produced by the kidney? That is erythropoietin. And anybody who's been on dialysis will recognize that name, erythropoietin, the drug that was developed by Amgen, oh my word, in the 90s now, that is the hormone EPO and is given just as if you would give insulin to a diabetic who lacks insulin to control their blood sugar. Erythropoietin can be given to replace the loss of this hormone. This hormone is located it's made by the kidney. So, and what's its job, as you all know, is it makes the bone marrow make red cells. So without the erythropoietin, the bone marrow does not produce enough of the red cells, and you get anemia. The use of these agents have now been approved for the treatment of anemia, and there's now the epoetin, erythropoietin, there's darbepoetin that is a little longer acting that can be used to treat that. Of interest, within the kidney, the way the kidney makes erythropoietin is it's stimulated by what's called the hypoxia inducible factor. The way the kidney knows, oh boy, I better make more erythropoietin, is because there is inadequate delivery of oxygen. Okay, so if you lived, I don't know, in Denver, your blood has less oxygen than if you live in lovely Orange County. And so the stimulation for this erythropoietin is a little higher, which is why people who live in high altitude sometimes have a little higher hematocrit. The finding of this system that induces the erythropoietin system was in the last several years gave the Nobel Prize to the very first nephrologist who identified it. And now there's efforts being made to get drugs such as vadadustat, roxadustat, approved for the treatment of anemia due to erythropoietin deficiency, particularly in kidney disease. And the interest in these is that this requires injections. This would be a pill. It almost got FDA approved recently, but there's still efforts trying to determine whether these agents will be safe and will not cause increased concern for things like cardiovascular disease. So we're awaiting final FDA comments, but I can tell you that these agents are available in other countries and may be approved in the United States. So that's the kidney's role in making EPO, erythropoietin. The last hormonal function of the kidney I'm going to tell you about is its role in vitamin D. Now, we all know patients with kidney disease get high phosphorus, low calcium. The hormone, parathyroid hormone, commonly talked about PTH, is high because largely due to a lot of the problems related to vitamin D. And people ask me sometimes, what does that have to do with my kidneys? That's because also, like the erythropoietin being synthesized in the kidney, the final active moiety of vitamin D, the one that does its real job, is in the kidney. So how's vitamin D made? We all know you got to go out in the sun. You can make vitamin D actually from cholesterol in the skin. And you can take a pill of vitamin D, which is called cholecalciferol, or vitamin D3, or D2, which is ergocalciferol, which is usually in plants, and this is in animal things. Okay, this vitamin part goes to the liver, and the liver converts it to what's called 25-hydroxy vitamin D. But that compound's not very active. In order to become the true active, which is 1,25-dihydroxy vitamin D, you have to go, it goes to the kidney where there's an enzyme that converts this, okay? In the presence of kidney disease, the cells that make these enzymes are deficient. They don't make enough of it. And you could supplement with these other types of vitamin D, but you'll lack the active moiety, which has been for decades now available as a prescription. And that's when you get things like Rocaltrol, also called calcitriol, in a pill, 125, and they are also parenteral. You can give it IV, okay, to maintain the level of vitamin D, okay? And so why it plays a role, what do we care about vitamin D then? I told you the vitamin D plays an important role in bone metabolism. So what happens in chronic kidney disease, you reduce phosphorus excretion, you alter calcium absorption because vitamin D loses its effect on the gut, okay? So then you start, the kidney says, let's stimulate this. I need to get rid of phosphorus. I need to increase the amount of calcium I have. It increases something called FGF23, okay, that ultimately increases parathyroid hormone. Unfortunately, if you have too much of these things, they can be considered maladaptive. So instead of preventing bone disease or other problems, these may exacerbate things like cardiovascular disease. The parathyroid hormone, while maintaining the calcium in your blood, which is important, will do so by mobilizing calcium from the bone and making the bone weaker. So and ultimately, as this calcium is not being appropriately placed in the bone, you can deposit in the circulation, and that's likely what's causing an increased cardiovascular risk. Additionally, the FGF23, which is being turned on by too much phosphorus, may also be causing cardiac problems. So that is why, even though the vitamin D and bone metabolism seems distant from the kidney, how the kidney function, or in this case, malfunction, is involved. Okay, so that is my brief overview of what the kidney does. It filters, it reabsorbs, it may secrete, and it handles those hormonal functions. And I hope that this helps to clarify some of the confusing problems with kidney disorders. And I open to any questions. I'm sorry, I don't think I can read the chat with my crazy new visual drama. But
thank you, Dr. Paul. There was a question.
Okay.
Are creatinine and cystatin, I can't say.
Cystatin C.
Yeah, thank you. It's a tongue twister.
Sure
Equally
is.
accurate in determining GFR.
Okay. The short answer is the average of both of those GFRs is the best. Okay. There are certain settings, for example, creatinine comes from muscle. So if you have a problem where you're losing muscle mass, your creatinine will drop because you're not making any, right? But let's say your kidney function is getting worse. You can't tell because the creatinine is in a level that fools doctors to suggest your GFR is good, all right? So then they use cystatin C. But cystatin C can be also not accurate in certain disorders, such as certain thyroid diseases, so you need to understand them. But the most current recommendation is to average both GFRs and use that equation that I'm sure you guys know, the CKD epi, and you do the cystatin C and creatinine, you get an average, you get an eGFR. Those are all available online if people want to do them. And that's the new best way to do it.
Thank you, Dr. Paul. I'm checking to see if there are any other questions. I think I have a PhD in the kidney now.
Okay,
Thank you so much. I mean, it's, we just kind of forget that they're the master chemists and they do so much. And then when they don't work, you have all these problems. But as somebody who's seen the evolution of kidney disease since the late 60s, you've really come a long way in understanding how the body accepts things, and like vitamin D, if your kidney can't activate it, it doesn't work. There is one question before we wrap up. If kidney damage is irreversible, why can eGFR go up in a subsequent blood test?
Because not all parts of reduced GFR are irreversible. So there may be a little inflammation that's not scarred. And if you control that, you can improve the kidney. There may be reduced GFR because your volume, you were dehydrated. You improved it, it went up. Okay.
Thank you, Dr. Paul. A lovely presentation. Check out her podcast. She explains things so wonderfully. Go to just put PAHL in RSN Hope, and you can hear other presentations she's given. Thank you so much. And I'm going to spotlight share here, and I'm going to remove your spotlight. Thank you, Dr. Paul.
Thank you.
Better. Bye-bye. And a shout out to our corporate mission partners for making this happen.